Hello, class. This is our group presentation for the final project of this class, and the facility that we visited was called Menorah Center for Rehab and Nursing Care. And this presentation is by Kelly, Sarah, Kate, which is myself, and Victoria. So, the agency that we visited is located on Manhattan Beach, which is in Brooklyn, New York, and it's on 10 oceanfront acres. It's actually a really beautiful facility. They recently renovated it and added a few other parts to it, and they're really enhancing it. They've been working on it for quite some time, and it's been really up and coming for a while. And it's beautiful too because it truly is oceanfront, and it's there's a great view and there's a really nice breeze, and a lot of the residents can kind of go sit outside if they can, or even when family visits and can take them places. It's just a really nice place to be. It's very pretty. It's clean, and it really is calming to look at the water and the skyline, and it's just very nice. And residents have actually reported positively on that they do like that view, especially in a place like Brooklyn and the city and New York in general. Having a nice kind of quiet, calm view like that is sort of not the norm all the time. So, this facility is a member of the MJHS family, and that stands for Metropolitan Jewish Health System. And that is basically a system where there are a lot of facilities that are a part of it. They mostly do home care, so it's a lot like the Visiting Nurse Service of New York. They focus on home care and rehab hospitals, and it's in Brooklyn, Manhattan, Queens, and Staten Island. It's basically, I think, in all the boroughs. So, Menorah is a not for profit social service agency. It caters to older adults for long and short term care. And during our visit, we actually spoke to several social workers in order to obtain most of our information, as well as we visited the sort of intake center and we got some brochures to sort of learn from and to kind of see what people who go there, what they receive in order to see if their family members would be a good fit for the place, or rather if the place would be a good fit for their family members. So the role of the social workers there is sort of variable. They mostly do case management. Actually, they pretty much only do case management. There are 5 social workers on staff. 2 of them are licensed social workers, and 3 of them are just master social workers. And let me just explain that a little bit. So, obviously, Rutgers is in New Jersey, so the majority of us who go there are from New Jersey, and therefore we are most familiar with New Jersey licensing regulations. So, in New Jersey, in order to work as a social worker, you must have a license. If you have a master's degree in social work, you need to have a license in order to actually be able to practice social work. Obviously, if you have a BSW or certified, it's I'm not really sure the rules with that. But for us, if you have an MSW from New Jersey, you do need a license in order to practice social work there. Otherwise, you cannot do it. However, in New York, you actually don't need a license. You can remain an MSW in New York pretty much forever. They've sort of been kind of trying to curb that though by giving MSWs this sort of 1 year grace period and sort of telling them that, well, you have this year to get your license, to take your exam, to get your license, and then, your pay will increase and we'll be able to keep you on staff. Otherwise, we'll have to let you go. But essentially, a lot of places don't actually let the social workers go. And really, as a social worker, if you really are that against taking the test and getting a license in New York, you can just get another job and then get that grace year again and again. And honestly, a lot of people are kind of just grandfathered into that. Now, though, they are starting to sort of implement more of that, like New Jersey, and I think like most other states where they do want licensed social workers to be the only ones getting hired, not just ones who've just gotten a master's degree but not taken their licensing exam. So on in this particular facility, there are 5 social workers. 2 of them are LSWs, or in New York, they're LMSWs, and 3 are MSWs. And actually, none of them that I spoke to are planning on getting their licenses anytime soon. They don't really have a timeline for that. So, and again, they are mostly responsible for case management. Um, if and when there is an intern, there are there are grief support, peer support, and caregiver support groups that are run. However, the social workers did tell us that when there is not an intern, which is usually the case, that these groups don't exist, that there's nobody to run them, that nobody has the time to do it, and that these social workers are really way too overworked for that. And I'll talk a little bit more about that later on in the presentation as well, about sort of the level of work and stress that they do go through. So there are several available services in Menorah. So one is the PASSR, which is the pre-admission screening and annual resident review, which is completed for each patient in the facility. If a mental illness is on file or newly identified, that is registered with the state. So in New Jersey, a pre-admission screening and resident review can be completed by a discharge planner or a social worker. In New York, the person doing the screening must be specially certified. The purpose of the PASSR is to assure that those being placed in a skilled nursing facility, or SNF, actually belong there. The Level 1 form screens for mental illness, dementia, and developmental disorders. The first section will screen for MI, dementia, neurocognitive disorder, which does qualify as a mental illness. Then the second section screens for dementia. If positive for both, that is called a dementia exclusion. Then DD is screened. If the screen is positive for MI with a dementia exclusion, this is considered a negative screen and no further action is needed. If the screen is positive for MI only, this is a positive screen, then a Level 2 screen is required. The screening document must be completed by a psychiatrist that is not the treating physician and is a complex 6-page document which requests information regarding mental health needs, physical needs, ADLs, meds for both psych and physical, recommended levels of care, things like that. And a positive Level 1 and Level 2 PASSR must be sent to the Department of Mental Health for a letter of determination to approve placement. It is also sent in New Jersey to the Division of Aging Services Office of Community Options to obtain a letter of clinical eligibility. If a Level 1 is deemed to be positive, but the patient is only going to go into subacute care, then the doctor can submit for a 30-day exclusion and a Level 2 does not need to be completed. So that's all pretty complicated, and the social workers there are trained to do this, and it's actually very useful because it does obviously work significantly with the mental health needs of the patients, which as social workers we would hope that they do, because a lot of the time in these facilities mental health is kind of overlooked, especially for the elderly population. So another service available is the rehabilitation, which is intensive restorative therapy. There are physical therapists, occupational therapists, speech therapists, swallowing pathologists, and audiologists available. There's also long-term care, which is offers medical and emotional support. There's a personal physician, nurses, case managers, post-surgical wound specialists, dietitians, social workers, discharge planners, physical NOT, speech and swallowing pathologists. There is an on-site health clinic with orthopedists, podiatrists, ophthalmologists, cardiologists, psychologists, and dentists. And there are specialized programs. There's music-assisted dementia therapy, respite care, hospice care, palliative care, post-surgical wound care, medication management. And there is a sense of community as well. There's live music, dance, art, cooking classes. There's actually a barber and a beauty salon, and there is spiritual support as well. Now, for demographics and funding, there are 420 beds in the facility, 3 floors with 140 beds per floor, available for short and long-term care. Currently, 414 of those beds are filled, and the population there is 80% Russian Jewish, which is also because that population, that part of Brooklyn, is mostly that population anyhow. In terms of funding, services for long and short-term care are paid in part or in full by Medicare, which is primarily for subacute rehab, and Medicaid, which is primary for room and board. Managed long-term care providers, private insurance, third-party payers, and people are also encouraged to donate to the facility as the center is not for profit and does not receive government funding. So in terms of recruitment, services at Menorah are marketed to potential clients by the overarching health system, which is MJHS, and their representatives in other facilities. While we could not find information regarding Medicaid and long-term care insurance, and sort of how many of those beds are paid for, we do know that Medicare, like managed or straight Medicare, pays for subacute rehab, which is 20 days without a copay. than 80 more days with a copay. So, in order to qualify for subacute, a 3 night qualifying stay in an acute care hospital is necessary, and managed or straight Medicaid or private pay is for long term care, like a room and board. So, some people have private long term care insurance, which covers the private pay as well. So, our first theme can be described in the following way. Older adults are not a monolithic group in terms of need for formal services and supports. Social, economic, and environmental inequalities pattern people's experiences of later life and how they interact with formal service organizations. So, old age itself results in its own inequality. Ageism causes people to only see the wrinkles and not look at disparities which have been evident throughout one's life. So, the elderly experience includes there's grief due to loss of friends, loved ones, and independence. There's, of course, declining health and physical mobility. And there's ageism, which is literally being treated differently because of your age. So there's a false belief that means that the playing field of disparity is leveled with aging, because if we simply adopt a positive mindset and make good choices, Social Security and Medicare will even it all out. So what this really means is that there's a false perception that once you are old, ageism is your only inequity. It means that somehow your race, sexual identity, religion, culture, and socioeconomic status disappear, and any disparity that resulted from those things goes away. Suddenly, you become an old person and experience only old person problems. The truth, though, is that, of course, you still have all the disparities, barriers, limitations as before, but now you also add in ageism. So the above statement, if we simply adopt a positive mindset and make good choices, is really unfair. It assumes that good choices were available to everyone, and we all know that they weren't, that that's not true. So, another truth is that white people with higher educational levels outlived black people with less education by 10 to 14 years. So, this is because social stressors affect health. Poverty and discrimination lead to poorer health and unequal access to medical care. Education influences cultural beliefs about illnesses, often slowing the process of seeking help and causing late diagnosis of ailments. Some cultures feel that dementia is actually going mad rather than a disease that can be treated and slowed down. Less education can be equated with a delay in seeking care, and poverty and lack of insurance leads to barriers and lack of access to services. So, certain medical conditions are more likely to affect certain groups. Some of this is due to genetics, but also much of it is due to financial and cultural barriers. Those with higher education are more likely to seek medical advice earlier and are more likely to embrace Western medicine. Less educated minorities are more likely to rely on cultural beliefs and less likely to seek assistance. Also, less money equates to poor insurance or no insurance and higher deductibles, out of pocket expenses, limits. Medicaid or no insurance is a barrier. And long term care is often not available at all to the poor. Medicaid beds are often limited, and it's important, of course, to embrace and support the at risk population. So, to educate them while still supporting and validating and while making sure to remain culturally sensitive. So, African Americans, older women, those with incomes below poverty lines are affected the most by this disparity. Those that need help the most often have the least resources, and wealthier elderly have more opportunities to engage in senior services and more social supports. It's well known that poverty does increase isolation. So, financial gaps remain, and Social Security checks do not make up the difference. The disparity of youth is carried into old age and then magnified by need. As the needs grow, the disparity grows. The wealthy have opportunities to engage in more social and supportive activities to keep them well. The poor don't have these opportunities, and therefore their health and cognitive abilities decline. So the wealthy stay healthier, and the poor only worsen. Menorah does accept residents from all socioeconomic backgrounds, and subacute short-term rehab is paid for by Medicare, and long-term care is paid for primarily by Medicaid. So this graph here on the right shows the percentages of payment for most skilled nursing facilities. So a quarter is paid by Medicare for subacute. Medicaid covers another quarter. The balance is paid out of pocket or by private insurances. Since Menorah's mission is to assist those in need, a large portion of their residents are in Medicaid beds. So what this shows is that most residents can stay at Menorah after they spend down their savings. So this facility will not kick the resident out when they can no longer afford to private pay, and many facilities only have a few Medicaid beds, whereas this is actually not the case with Menorah. And Menorah does accept residents from all cultural backgrounds. Even though the population is 80% Russian Jewish, there are all ethnicities and spiritual beliefs that are welcome there, honored, and respected. The The focus is on at risk members of the community, and Menorah's promise is to provide care with compassion, dignity, and respect. The staff is multilingual to accommodate many ethnicities, and there are translators if needed. And there are multiple therapeutic modalities to address personal needs. There's also music, art, dance, and cooking opportunities. So there's a lot of interesting stuff, and that as well does embrace all cultures and ethnicities. So our second theme deals primarily with supportive services. A major challenge for aging services providers is to ensure that older adults and caregivers can access supportive services, especially among older adults and caregivers who are already underserved. So, as of course you all know from this class, we did go over a lot of material that spoke about caregivers really not receiving a lot of the services and things that can be so helpful for them. So, that is a really big issue, especially with people who are taking care of elderly people or sick people at home. And even in facilities like this, it's still, caregivers still need support. And like we did mention, that unfortunately, unless there's an intern, there just aren't really groups or any kind of resources for them to really get help. So, Middleman stated that the stress associated with caring for an older relative suffering from Alzheimer's disease or another dementing illness is often considerable. The behavior problems include depression, agitation, wandering, and incontinence, and those are among the most challenging stressors for caregivers and are a major cause of nursing home placement of patients. Then Atkins stated that a little more than half are older than age 65 and have either entered retirement with chronic illnesses or conditions which require long-term supports and services. And those needs develop in old age and can be anticipated and prepared for to some extent, although few people reaching age 65 have actually done so. So supportive services can be defined as there's the Older Americans Act, Title III grants for state and community programs on aging. So access services, which are information and referrals, case management, transportation, home and community services, which are personal care, adult day services, chore services like cleaning and grocery shopping, nutritional services such as meal programs, and educational services for disease self-management, legal services, and mental health services. So caregiving, of course, is tough, and these people do need support, as much as the people that they are caring for need support. So 80% of older adults who receive care will get it through informal caregiving. 1 in 3 households has a caregiver. Caregivers typically work more and give more economically than other formal types of funding sources for long-term care services, such as Medicaid or Medicare. And there are supportive services available for caregivers through Title III. There are specialized programs for caregivers through the National Family Caregiving Support Program, which are support groups. Then there's care management, educational programs for support, respite care, and adult day services. So Menorah offers some support services to both older adults and their caregivers. There are creative arts therapy programs for patients and families, including who could be caregivers. Then there are home health aides for after the patient's discharge through their private insurance or through Medicaid or Medicare. There are, of course, volunteers who help with support for both patients and caregivers in the center and after discharge. There is also bereavement support. There are psychoeducation groups and support groups for up to 13 months after the death of a loved one. And those are not contingent upon an intern. Those are actually provided by the social workers. There are people designated to run those groups. There are different levels of hospice care depending on where the patient is in the stage of their illness. So there's routine home care, general inpatient care, continuous care for at least 8 hours a day and up to 24 hours, and respite care. There's also physical therapy, occupational therapy, respiratory therapy, speech and language therapy, nutritional counseling, and dietary programs. So for long-term services and supports, there is a need for financing solutions. So the cost for long-term services and supports, according to Atkins, is a lot. Most older people who do need round-the-clock care receive it from an unpaid caregiver, probably a spouse or a child, but as we know, this does take a toll on the relationship between the caregiver and the person being cared for, and it does take a toll on the caregiver's life. Eventually, the older person will be in the care of a paid caregiver, but the tricky part is that the finances that go into that. So the amount of money that will go into this depends on a lot of factors like length of time, what services, and of course what the person is treated for. So, according to Atkins, at this point in time, more research does need to be done to figure out the answer to financing solutions. And what we do know is that some type of public policy regarding funding needs to be adjusted and made to fit different population needs. Menorah offers round the clock long term care for many different paid caregivers. There are primary care physicians, RNs, case managers, physical therapists, OTs. There is not an exact cost of what long term support services are on their website, and when we asked them, they really couldn't give us a number, but it is probably really costly since we did learn that these support services are a huge financing issue for people. So there are, once again, different payment options. There is private insurance, self-pay, Medicare, or Medicaid, and there is also Home First, which is part of Elder Plan for managed long-term care. The third theme that we will be discussing is as follows. Family caregivers, many of whom are older adults themselves, can be thought of as both consumers of services as well as partners and providers of services. Niles, Yoakum, and Wagner state that there is an increasing percentage of older caregivers over the age of 75. Most were caring for a spouse, 20% were caring for a friend, 20% were caring for a parent, and 18% were caring for a sibling. Most older adults would rather their family or friends care for them than strangers. Unpaid care by family and friends, by friends and family made up 80% of all long-term services used by older adults, and approximately $234 billion in caregiver services was provided on an unpaid basis. Also, about 75 hours of caregiving support were given each month. The ultimate theme is that caregivers deserve services too. Their help is imperative to the well-being of older adults. So here we will further dissect the theme into how caregivers are consumers, partners, and providers of services. So older adult caregivers often use the services deemed for the care recipients themselves. For example, respite services usually provide a break for caregivers to prevent burnout. Transportation services are often used by the caregivers themselves as they are older and cannot drive their care recipients to appointments. Also, geriatric care management services can help caregivers by planning an array of services for their care recipient. As far as caregivers as partners, oftentimes caregivers are deemed the go-to person when coordinating care for an older adult. Social workers should partner with caregivers to ensure service utilization and the best care for older adults. Finally, caregivers as providers of services state that caregivers coordinate care, provide transportation for the older adult to appointments, make the appointments, and oftentimes refer older adults to places of care. Caregivers are often an important lifeline, safety net, and support system for the care recipient. With this in mind, caregivers provide most of the services to our clients. So, as stated beforehand, older adult caregivers are increasing in number as well as caregiving overall. How can we, as social workers, advocate for this mostly underserved population? In this slide, we will talk about the most pressing matters that are needed for caregivers all over the country. Illness education provided to the caregiver is needed. For a caregiver to fully understand what illness is present and how to help the care recipient, this is an important service. Many caregivers do not have education in the medical or mental health field and may miss some of the signs and symptoms of an illness that another professional might catch. Respite services are important to caregivers because they provide them the much-needed breaks that they need. Emotional and physical supports are also necessary, as it was mentioned beforehand that caregiving is a tough job and it can provide many burdens for the caregiver. Making sure that caregivers are in optimal condition ensures that services for older adults can be carried out longer. Assistance for transportation is also needed and is actually something that Niles, Yoakum, and Wagner specifically advocated for the expansion of. Social workers can help caregivers in selecting the best home health care agency or assisted living facility for their care recipient when it is time. Caregivers, often friends and family, will obviously want the best care and will trust our judgment. A service that is highly needed is more flexibility at work for caregivers. Many have to give up their jobs or take significant time off because they cannot balance caregiving and working full-time. Social workers can advocate for policy change in which caregivers are given benefits that will allow them flexible schedules to ensure that caregiving is given to care recipients. It should be remembered that older caregivers report a higher level of burden than do younger caregivers. So, what is the government doing to aid caregivers? The HHS Office of Women's Health is collaborating with HRSA to develop training modules to help provider-caregiver communication and to help family caregivers maximize their own health. U.S. Health and Human Services released a fact sheet educating caregivers about insurance coverage. U.S. Department of Transportation provides technical assistance to improve accessibility of transportation options that serve the needs of caregivers. React, Care.com, and MIT collaborate to generate tools employers need to effectively care for an employee that is also a caregiver, and Transamerica Institute supports and conducts research on how caregiving needs are impacting Americans. As stated earlier, Menorah has some services and programs that caregivers may be involved with, but none are actually explicitly for caregivers. Some examples of earlier stated programs that can benefit caregivers are creative arts therapy for patients and their families, home health aides, support groups if an intern is available, discharge planning by volunteers. And why would it be beneficial for Menorah to expand their caregiver services and programs? Well, caregiver well-being is important to the care recipient's health. They cannot take care of others if they can't care for themselves. Also, family caregivers do make up 80% of long-term supportive services, so without them, there would just not be enough resources to take care of all the older adults. And increased institutionalization rates without caregivers would be something that happens, as older adults would not be able to care for themselves independently. The major advice that we would like to give Menorah is utilize the growing social work field and hire more social workers. Menorah only has 5 social workers on staff at their agency for thousands of patients. Additionally, these social workers are only in charge of case management services. The field of social work is growing, with thousands of social workers graduating every year with their MSWs. The advice that we would give is simply to expand the social worker role in this agency. Services to consumers at Menorah can be expanded greatly if more social workers were on staff to assist with discharge planning, support groups, hospice care, more case management, and even more. Moreover, it would not be difficult to expand caregiver services and resources if more social workers were employed for these roles only. In addition, the social workers are highly burned out in this facility and really do struggle with having just a lot of work and a lot of families who call them up about the patients, and there are some arguments and some issues, and honestly, the understaffing is a really huge issue for the workers, for the families, and for the patients. Overall, this is a great facility, and it does have some things that it definitely needs to fix. So the summary and takeaways that we as a group got from going to this facility and from creating this presentation is, of course, our themes. So theme 1, we got that ageism is important and should be focused on more than it is. Social workers should be culturally aware and competent enough not to implicitly contribute to race, socioeconomic status, cultural, gender, or disability barriers that exist. These barriers and disparities that exist for the young only grow wider with age, and Medicare and Medicaid do not even out those gaps. And differences need to be embraced and respected at every age. As far as theme 2 goes, it is important that a social worker be aware of the supportive services available to their older adult clients, as well as to caregivers, which will go into our third theme, that caregiver services should be increased in every facility as they are the backbone of our clients. Older adult caregivers should be paid extra attention to as they are increasing in numbers, but also stay at a higher level of burden than their younger counterparts. And caregivers' mental and physical health should be important to us. Without caregivers, we would not have nearly enough resources to support older adults. As far as what our group got from engaging in this project, of course, it enhanced our leadership development. It allowed us to evaluate this facility, to evaluate Menorah from the perspective of what we learned in this class, and also just from our enhanced understanding of caregivers and the care recipients and of the systems, Medicare, Medicaid services, these facilities. So pretty much all of that put together really helped us go into Menorah and to look at it through a different lens, through an enhanced lens that we gained from a semester in this course. One thing that we were reminded of was Chad Alley, who was an advanced social worker who discussed leadership in a recent podcast that we saw. It was called Leadership and Social Work, and it was a 2015 podcast. He stated that he felt that leadership and social work was significantly lacking. So despite his good education and excellent experience, he just felt that there really wasn't enough leadership, that no matter what was going on, no matter how he was learning, he felt that there was so much more that could be done. So I do agree with Mr. Alley, and I think that we all do, that he felt that something was sort of always missing. So I feel that in terms of that podcast, in terms of his messages, I feel that doing something like this kind of project and going to this facility did enhance our leadership ability. And like I said, being able to look through it, being able to look at it all through this lens that we've gained as a result of our time at Rutgers, as a result, of course, of this class and of all the materials that we utilized, of the discussions, of our conversations with one another in groups and as classmates. I feel like this was really excellent exposure to the kind of leadership that we can accomplish, even though most of us are clinical social workers at this point, at least in this class, or at least in our group. Still, the ability to do this kind of work and to really immerse ourselves in it for this semester was important and really eye opening. So, we hope that you enjoyed our presentation, and thank you so much for listening about this facility. And we really did enjoy visiting it and learning all of this really important information. And lastly, these are the references for our presentation. Once again, thank you for watching, and I just wanted to quickly talk a little bit about the 3 points that we needed to address here, which are preparing for the visit, conducting the visit, and analyzing and presenting on the visit. So for preparing for our visit, we really just tried to find facilities that would work for our project, and we tried calling a couple of facilities. We did some in Jersey, some in New York, and we settled on Menorah, which was in Brooklyn. We were just really looking for a facility that would be okay with us coming over and kind of would answer our questions, and one that we felt would one that we felt had good reviews and things like that for their patients and clients. So that's how we settled on Menorah in Brooklyn. Then for conducting the visit, we just got our schedules together. We found the best time for us to visit, and we were able to visit during the allocated week, which I think was week 8 of the class, which that was perfectly fine. And then for analyzing and presenting on it, we just created the PowerPoint. We asked several questions when we were there. We saw the director of social work. We met with various social workers. We even saw a few patients. We got a little tour of the facility. So, it was all pretty standard, and everybody was really comfortable talking to us about it. And it was just overall a very good visit. And once again, analyzing it, we were able to find a lot of information in the literature. We were able to come up with 3 good themes, and really we were able to just learn a lot about this facility and see, sort of how it exemplified the things that we learned in this class.